Good afternoon and welcome to another live broadcast with MedStar Health. My name is Karen Zingle and today we are talking about the importance of cancer screenings. I'm joined today by Dr. Jennifer Flaim, a diagnostic radiologist at our MedStar Health Bel Air Medical Campus, Clara Yoder, a lung nurse navigator at Angelos Center for Lung Diseases at MedStar Franklin Square Medical Center, and Dr. Jasmine Barrow, a gastroenterologist at MedStar Health Gastroenterology in Lutherville. Today, we'll be discussing how the pandemic has caused a decline in cancer screenings and why this is such a concern, especially when it comes to lung, breast, and colorectal cancers. We invite you to stick around as we have this important discussion, ask your questions in the comments, and share this broadcast with your friends. You can also give us a like, let us know you're watching. So let's first by kicking off the conversation with Dr. Jennifer Flaim. Good afternoon, Dr. Flaim. How are you?
I'm good. Oh, am I? Yes, I'm unmuted. Okay.
Well, why don't you start by just telling us a little bit about yourself?
I am a diagnostic radiologist and I am subspecialized in breast cancer and women's imaging. I've been with MedStar for 5 years now. I'm originally from the Baltimore area and I'm very happy to be here today.
Wonderful. Thank you very much. I have some questions for you, but before we do that, I do want to introduce the rest of our experts. Dr. Barrow, why don't you go ahead and introduce yourself to our viewers?
Hi, everybody. I'm Dr. Jasmine Barrow. I'm a gastroenterologist here at MedStar. I practice at Franklin Square as well as our Lutherville location. I've been with MedStar for about 7-8 months now, and I'm happy to continue the discussion on colorectal cancer screening.
Thank you very much. And Clara, why don't you introduce yourself?
Thank you. My name is Clara Yoder. As already mentioned, I'm a lung cancer nurse navigator. I work here at Franklin Square physically, but I do cover both Union, Good Sam, Harbor, and Franklin for our lung cancer patients in particular. I've been with MedStar approximately 10 years, and I came into this field because of a personal passion with lung cancer. So happy to be here.
Wonderful. Thank you so much. Let's get into our questions. Let's start with Dr. Flaim. Dr. Flaim, can you tell us why there's been a decline in cancer screenings and why is this so alarming?
So to begin with, back around this time last year, we were becoming aware of this pandemic. Things were starting to shut down. And I think initially we had to shunt our resources. We knew that we had a limited number of radiologists, physicians, nurses, staff that could be at our hospitals at any certain point, that could provide the tests that we needed for people that were imminently ill. And so initially we had this shunt from screening exams, which are in general just well people who are doing surveillance exams to make sure that all of the people that were ill had the resources that they needed. So for a period of time, and this is not just MedStar, this is across most health systems, there was a pause in screenings. And for us, I believe that was from March through June. We had pretty much a complete pause, and then we started to open things back up. And that's really alarming because screenings have the potential to catch cancers before they're clinically evident. Precancerous lesions or small cancers when they are the most treatable with the least impact to your life expectancy, to your what we call morbidity, how invasive the procedures have to be to cure you of that disease. So delaying screenings for an extended period of time, there's going to be what we call a missed period. So the cancers those patients that do come back after this long pause, we may be finding cancers that are more advanced or larger at a more advanced stage or require bigger or more complicated surgeries or procedures for cure. And this is really a complicated story. We don't have all the information and all the pieces yet. Over time, this is the full impact will reveal itself, but we do have some models, mathematical and data models that we look at to see what the future impact could be. On the other hand, there was a lot of messaging out in the media about this virus. And a lot of people were very concerned about what it was going to mean to come into a healthcare setting. For a lot of healthcare providers, we weren't sure either. But again, over time, we have figured out some risk mitigating factors where we feel like we can, again, bring people into the office or certain people into the office safely so that we're not excessively delaying these screeners so we don't have so many missed cancers.
Thank you very much. Thanks for addressing that. I know that was a lot of questions and comments that we got from our viewers, and certainly understand that there was a lot going on in the last year. So a lot to think about. So thank you for that. Let's talk about those different types of screenings now, and specifically talk about breast cancer first.
Okay.
What can we talk about risks? Let's talk about who is at risk for breast cancer.
Sure. So I'm going to kind of combine this with another really common question, which is who should get screened?
Great.
Because they kind of all go together. Who's at risk for breast cancer? Anyone with a breast. You know, if you're going to get down to the nuts and bolts of it, but who do we choose to screen? If you look at the different societies, this is confusing too. The messaging has been confusing because different societies have recommended different things. I go with kind of collectively the American Cancer Society, the Society of Breast Imaging, the Society of Breast Disease, and the American College of Radiology all recommend annual screening mammography, meaning every year starting at the age of 40. There has been some mixed messaging about starting later, but we also know that 1 in 69 women will have an invasive breast cancer in their 40s. So this recommendation is based on most number of lives saved. So that is what we recommend. The upper limit is a little bit hazier because what we recommend is as long as you are healthy enough to come in for a mammogram, and that can be a little bit more confusing who is healthy enough, but that needs to be a discussion with you and your healthcare provider and your life and health goals.
Thank you very much.
Not too confusing.
No, that was great. Thank you. I was just unmuting myself. Can we talk about the steps that you can take? So if you talked about the risks already and who should get screened, what steps can you take and what are the benefits of getting screening?
Well, the benefits, I've kind of already touched on. The benefits of screening is really finding those preclinical cancers before you feel a lump, before you have any symptoms, sometimes before it's even an invasive cancer. In the case of breast cancer, you know, we can find what is DCIS, which is a grade 0 pre-invasive cancer. And so that, you know, that gives patients an excellent prognosis for their success. I've lost my train of thought.
The steps that you can take.
Yes.
What about the steps you can take? That's okay.
So one of the things is knowing your risk. You know, there are formal risk assessment models. And if you think you might be at increased risk, making sure that you talk to your doctor about one of those risk assessment models to determine if you would benefit from earlier screening can be helpful. You can't change your family history, unfortunately, and you can't change your sex. And those are two of the biggest factors. Obviously, women are going to be at a higher risk than men. There are certain things like making sure that you maintain a healthy body weight, because we do know that excess fat tissue can contribute to an increase in circulating estrogen and an increase in breast cancer. So trying to maintain a healthy body weight, decreasing alcohol consumption. I always tell patients, you know, self-breast exams are also somewhat controversial because breasts are lumpy and bumpy, but knowing your lumps and bumps can be really helpful in terms of knowing when there's a problem and when you need to seek help.
Okay, thank you very much. What are the different types of screenings and specifically the different types of mammograms that you can get? I know there's some different types of technology available. Can you address that?
Yep. So screening mammograms are done in asymptomatic patients. You have breasts, you have no problems with them, but you want to make sure there's nothing going on there. So you come into our office and you get generally 2 views of each breast, and then you go home. And I or one of my esteemed colleagues will look at it and see if there's anything suspicious there. And that's all that screening entails. If we see something that's concerning to us, and or if a patient has something like a lump or a focal area of pain or nipple discharge, then we do what's called a diagnostic mammogram, where we sometimes do those same views, but we do additional views. We may do spot compression views or magnify the breast. And that's called a diagnostic mammogram. And that has more to do with whether or not you have symptoms or a potential problem that we've already detected. We also use ultrasound on the breast. A lot of patients ask me if they can just have ultrasound. And unfortunately, a lot of those precancerous DCIS lesions would not show up on an ultrasound. So they really are meant to be used together. Let's see. We also do screening MRI, which is not for everybody. It's incredibly sensitive, but it is really best used for patients with an increased lifetime risk of breast cancer based on one of these risk assessment models where someone's breast cancer risk would be over 20%. So sometimes we do those for patients every year as well. That's a conversation to have with your primary doctor, whoever does your breast care, to determine your risk. I can say, I know at our Bel Air office, and I think at several of our other offices as well, we have what's called the smart curve paddle. And a lot of women don't want to come in and get squished, but this curved paddle, you know, it's kind of shaped like this, and it's not for every breast, but it's designed to follow the contour of a breast so that we can use much less compression to get a uniform thickness and move some of that breast tissue out of the way. And that does tend to make patients much more comfortable. One of the things that I get asked about all the time is 3D mammography. That is no longer new for us. We offer that to everybody. So everybody that comes to us can have a 3D mammogram.
Thank you. So a lot of different options for you that you can discuss with your provider. Can you talk about what are the steps that are being taken to ensure that our patients are safe coming in? We talked a little bit about this earlier and how things have definitely changed since this time last year, and more and more people are feeling comfortable going out. Maybe they're vaccinated, but then on top of that, what are we doing to keep them safe when they come in for their screening?
So depending on the facility, and I think it's fairly uniform from one facility to the other, but there is distancing in waiting areas. You know, we have no touch check-ins and things like that. All of our staff are wearing the appropriate PPE or personal protective equipment. Sometimes that includes shields. So if you see someone with a big plastic face shield on, don't be alarmed. Certainly masks, eye protection. And when possible, we are also still trying to physically distance. In mammography, that is, at least for short periods of time, not possible. Getting someone positioned or doing a biopsy, we are in close proximity, but we mask. We do intense cleanings in between patients to ensure that surfaces are cleaned. We try to leave rooms and doors open in between patients to promote improved air circulation. And let's see, I'm trying to think if there's anything else specifically to breast. I mean,
that's okay.
yeah.
It sounds like we're taking all of the precautions that we need to, following guidelines with our counterparts of the CDC and across MedStar to ensure that our patients are safe coming in.
One more thing that I know that we're all doing, because I know I get a text every morning. Every MedStar employee has to fill out, you have to fill out your health questionnaire every day, even when I'm not coming to work. I have to say, am I going to be in a facility? Yes or no? If yes, are you experiencing or have you experienced any of these symptoms? So that is to hopefully, you know, make sure that no one is coming to work with any sort of symptom.
Yep, thank you. Just filled mine out earlier this morning, 6 a.m. So what happens after? So you come in for a screening. What happens if something is found in that screening result?
Right. So if something is found, you will get notified by our facility that we need to do a callback. And that just means we're going to bring you back and do additional imaging. That could be any one of those modalities. It could be additional mammogram images. It could just be an ultrasound. It is typically not straight to MRI. But then at your diagnostic visit, you have a meeting with your radiologist. I know I always, if we're going to call you back to do anything else, especially if I'm going to compress you again, you're going to get a conversation face to face with me, and you're going to leave that day with an answer. And that means everything looks okay. We'll see you next year. That mass we saw was just a simple cyst. all the way to, hey, I think we really need to do a biopsy. This is a discussion we have to have. Even so far as this is highly suspicious and I'd really like you to see the breast surgeon. We're going to do a biopsy, but let's get you set up because I'm very suspicious about this. But it does involve a face-to-face conversation. Patients have an opportunity to ask questions because it can be a very high stress and emotionally charged time. So we try to make sure we're there for patients, especially in the midst of a global pandemic where everyone's life has been turned on its ear.
Thank you very much, Dr. Flaim. If you're just joining us, we are live talking about cancer screenings with Dr. Jennifer Flaim, diagnostic radiologist at MedStar Health Bel Air Medical Campus. We're also here with Clara Yoder, a lung nurse navigator at the Angelos Center for Lung Diseases at MedStar Franklin Square Medical Center, and Dr. Jasmine Barrow, gastroenterologist at MedStar Health Gastroenterology in Lutherville. So we had some wonderful discussion about cancer screenings in general, what happened over the last year, and then specifically about breast cancer. If you have questions for our experts, we're going to move on to lung next. But if you do have any questions about breast, colorectal, lung, or cancer screenings, please ask them in the comments and share this with your friends. If you haven't liked this broadcast to let us know you're watching, please go ahead and do that. So let's move on to Clara Yoder. And first of all, thank you for joining us today. Let's talk to you about lung cancer. Similar question that I asked Dr. Flaim. Can you talk about who is at risk for lung cancer?
Of course, and similar to Dr. Flaim, it's really kind of, who do we recommend to get screened? And so for lung cancer in particular, we are looking for typically patients currently 55 and older. Depends on our insurance as far as, unfortunately, kind of where that recommendation is, whether that's 77 or 80 for our private insurances. But as Dr. Flaim mentioned, really screening is for patients who are not symptomatic, so no symptoms. And those who have a very strong smoking history in lung cancer is kind of our #1 risk factor. So when we're talking about smoking, we're looking at, are you currently a smoker or are you a former smoker? If you have you quit within the last 15 years still? And how much are you smoking, or how much were you smoking kind of at the time of your smoking? So current recommendations or guidelines revolve around a 30-pack year history. So what does that mean? That you're smoking on average a pack a day for 30 years. So that's quite a bit for some patients, and for some patients, they don't think that's a lot, but when you perhaps maybe add up how long you've been smoking, you may be hitting that. The United States Prevention Task Force actually just released some new guidelines for lung cancer recommendations. So there are advocacy groups and organizations that nurses like myself and doctors are involved with, where we're looking at having approved actually lower guidelines. So we're actually looking currently at reducing that to the age of 50 and a pack history of 20. So we're really hopeful that we can even get more patients screened and prevent even more lung cancers with that here soon.
Okay, thank you very much. Can we talk about the warning signs? What are the warning signs for lung cancer?
So good question. So lung cancer in particular, we kind of call a silent killer in the sense that, unfortunately, symptoms, there really aren't any until we typically have an advanced stage or a late stage cancer. So often patients will not be aware that they have lung cancer at early stages because you don't have symptoms. That chronic cough that you may have as a smoker doesn't necessarily change until later in the progression of a cancer potentially. But things we often warn patients about is obviously a chronic cough that you're unable to clear for any extended period of time. So not just that sinus postnasal drip that lasts for a couple of weeks that clears, but months of, unfortunately, a chronic cough. Hemoptysis, which is when you're coughing up any form of blood, does need to be discussed with one of your providers, whether that's your primary care, or if you do see a lung doctor, a pulmonologist. That is always something that we're concerned about that needs kind of further investigation. As Dr. Flaim kind of mentioned, sometimes obviously we want to do lung cancer screening, but if patients are having symptoms, we may often recommend a diagnostic CT instead. So we have ways, obviously, to look into some of these symptoms if there are any.
Thank you very much. Why is delaying a lung cancer screening so bad? Why should you not delay?
So as mentioned, obviously, we know with the pandemic, many patients have delayed because of certain personal circumstances, as well as circumstances of our entire healthcare system. Many screenings were paused on purpose, as Dr. Flaim mentioned, because of resources and just concerns for our patients' overall health across the board. And so in lung in particular, we're always trying to promote more and more people to be scanned, because currently, research basically shows that we are only, unfortunately, screening about 16% of patients at an early stage versus a later stage. So we want patients to get screened earlier. And then our kind of last large research study showed that out of the 6.8 million identified patients in the US who were eligible for lung screening, only about 5% of those patients were actually screened. So in lung screening, we have a long way to go to educate our doctors, our patients, our family and friends. So we are always on the push to get that lung cancer screening if you may be eligible or interested. But so as Dr. Flaim mentioned, the earlier we can find these, the more treatable they are. That's definitely true in lung. And we want to be able to obviously find these early to give patients the best overall prognosis.
Thank you. Is a screening the best or only step that you can take to find lung cancer early?
So there was a research study that actually looked at chest x-rays versus low dose CT scans. And so that's really how we came across having that as our baseline recommendation for a low dose CT scan. We get a lot of questions about that amount of radiation versus a chest x-ray. And so a low dose CT scan is less than half of your kind of background atmosphere that patients are often exposed to. So we definitely recommend, unfortunately, that kind of radiation to minimize a patient's potential risk of lung cancer. And I lost my train of thought as well.
That's okay. We were just talking about steps or ways that you can find lung cancer early, and I was wondering whether or not a screening is the best or only way to do that.
Yeah, in lung, typically screening is really the end all be all, in the sense of, because lung cancer does not have symptoms early on. And so we really do recommend patients to talk to their primary care physicians and their lung doctors about their potential risks. But the best thing any patient can ever do for themselves is to quit smoking if they're currently a smoker. That is our number one risk factor. So we're always obviously promoting ways that you can quit, or at least try to cut down, at the very least, to try to minimize your risk. So that's always our number one goal.
Wonderful. Yeah, that's a great tip. Thank you. Can you talk about a lung scans? What is it and how do they work?
Sure. So for patients who may not be familiar with a low-dose CT scan, it is a painless procedure. A patient will come in and obviously sign in. The paperwork probably will be the most painful part, hopefully. But patients are coming in, obviously, they're laying on a flat table typically. For lung, we get a lot of questions because obviously with lung patients, if they have any sort of other lung issues going on, they get short of breath perhaps while laying flat. There are ways for us to kind of minimize that as best we can. So, just make sure you're talking to your radiologist and the technicians that you do get short of breath when you lay flat. But typically you're laying on a table, and that table slides in and out of basically a fancy donut, to be honest with you. So there's no contrast involved for a low-dose CT scan. So it's a very quick procedure and we get a quick answer. So hopefully, it's worth the trip.
Great, thank you. We do have a question from one of our viewers for you. It's from Betsy. Thank you, Betsy, for asking this question. She asked, what if you have a chronic cough over a year but never were a smoker?
So even patients who may not have a smoking history, unlike breast and some other cancers where family history plays a larger role, those are still things we and doctors will ask you about. So like your family history, maybe your exposures, things like asbestos and radon. In the state of Maryland, we have radon in our soil. It is a gas that's released through our soil. So if you have a very old house that maybe has not been checked, or you have a job that you have been exposed to asbestos or, a craft even, those are things that we want you to come in and talk to your doctor about. So a chronic cough for most patients, most of the time is something we always want to look into just to make sure it's not something asymptomatic. So just something always to check into.
Great, thank you very much. And thank you, Betsy, for that question. If anyone, any of our viewers have any questions for our experts, just a reminder to post them in the comments. Can we talk a little bit about the lung scans and the benefit? There's obviously benefits of getting the screening. What if a person does not have insurance for a lung scan? What can they do?
So good question. So as I mentioned, advocacy groups are currently working on expanding our guidelines to get more and more people covered. And so we will continue to do that work because we believe strongly about getting patients scanned. But in our area, the Baltimore City and Anne Arundel County, for example, have programs where they cover scans for absolutely free. That's one of the grants and so forth we have here in the MedStar program. So we do have resources. We work with patients. There are some self-pay options as well and payment plans that can be done with certain radiology groups. There's several in our area. So obviously here at MedStar, we work really hard with the patients to get these screenings because we believe in them. And so we will work with the patient as best we can to get that done for them. But most insurances, actually all private insurances, and cover lung screenings, assuming that you fit criteria and concerns and risks.
Thank you very much, Clara. So we, just to remind our viewers, we have been talking about breast cancer screenings, lung cancer screenings. Next, we're going to go to Dr. Barrow and talk about colorectal cancer and colorectal screenings. So Dr. Barrow, can we, I'm going to ask you the same question I asked Dr. Flaim and Clara. What are the risk factors for colorectal cancer?
You're going to hear some similar themes here compared to breast cancer and lung cancer, but I like to think about the risk factors for colorectal cancer in two kind of buckets. You have your modifiable risk factors, and there are those things that you can't modify. So those modifiable risk factors, I'm going to put smoking at the top of that list because that does increase your risk for colorectal cancer as well. Alcohol use can increase your risk for colorectal cancer, and obesity. Those are probably the three top things that are modifiable that you can reduce your risk of colorectal cancer if you eliminate those things from your lifestyle. But then getting into the things that you can't modify, age is really the top risk factor here. And that sort of dictates a lot of our screening. After the age of 50, there's an increased risk of colorectal cancer. But we've actually have noticed in the last 20 years that there's an increasing rate of colorectal cancer in those patients who are between the age 45 and 49 as well. Other non-modifiable risk factors include inflammatory bowel disease, which is a focus of mine, and that includes Crohn's disease and ulcerative colitis. So when there's chronic inflammation in the colon, it increases the risk of developing changes in the lining of the colon that can lead to colorectal cancer. There's also some studies that demonstrate there could be an increased risk of colorectal cancer in those patients with diabetes. it's kind of confusing because some of the things I mentioned already, such as obesity, can kind of overlap with diabetes. But I think there's been some research that demonstrates diabetes in and of itself may increase your risk for colon cancer as well. The last thing I want to mention that increases your risk for colon cancer includes some genetic or hereditary type of disorders. So a family history of colon cancer increases your risk of colon cancer, as well as a family history of what we call an advanced polyp, which we can discuss a little bit more later. But those are the main risk factors of colon cancer.
Thank you very much. So it sounded like some of those things you can't do anything about, your age as an example, or potentially your hereditary risk factor. But smoking was one of them, that it's a risk factor that you can choose and prevent to help prevent colorectal cancer. Is there anything else that you can do, and can colorectal cancer be prevented?
Good question. So we're here to talk about screening for cancer. So absolutely. So we recommend screening for colon cancer, which is a method of preventing colon cancer. With screening, we can detect the lesions, we call them polyps, that we know over time can become a cancer. Also with screening, we can detect early colon cancers that are more easily treated with less invasive or less morbid treatments if compared to a more advanced colon cancer. So colonoscopies are our main method of screening for colon cancer. A colonoscopy is a procedure that requires anesthesia, that includes using a scope, which essentially is a long tube. It's about a centimeter in diameter and has a camera and a light on it. I find it to be pretty cool. So we can insert the colonoscope into the rectum, and I can see around the entire colon. I can see the inside lining of the colon directly, and I can detect any changes that I'm concerned about, particularly these polyps, and then we can remove them. So it's an excellent method of, one, preventing colon cancer, or screening for colon cancer, and preventing colon cancer by removing those polyps.
Thank you. Why is delaying a screening? I'm going to ask the same question. Why is it so bad to delay your screening for a colorectal cancer?
Well, similar to what I was just mentioning, is that we have the ability to resect or remove these precancerous lesions, and so the longer you delay your screening, the more time has gone by that can allow for these polyps to become cancer. And when I'm doing screening colonoscopies, I know that I'm going to see polyps in about 25% or even more of patients. So there's a very common occurrence to have a polyp in the colon, and therefore, if you delay your screening, you're just giving that polyp a chance to become cancer down the line.
Thank you. So you mentioned colonoscopy. What type of screening is the best type of screening, and why is colonoscopy the best to do?
Yeah, so colonoscopy is one method of screening that I mentioned, but there are other methods that include stool screening for colon cancer. There are probably two types that I would say are the main types. One is looking for like microscopic blood in the stool. And so we know that when you have a colon cancer, it can slowly bleed or lose blood in a microscopic way that you can't see in your stool. And so these tests are designed to pick up that microscopic blood in the stool. And if positive, you would need a colonoscopy to go and detect where it's coming from. There's also a stool study that looks at abnormal DNA that we think comes from a colon cancer. And so if you have that abnormal DNA in your stool, again, you would be recommended to have a colonoscopy to go and detect where that could be coming from. The problem with those studies is that if they're positive, you have to have a colonoscopy afterward to detect where it's coming from. With a colonoscopy, and I should also mention, those tests are not as good at picking up polyps, which is really, I would try to drive home, like finding the lesion at the time where it's a polyp is really your ability to, prevent that polyp from becoming colon cancer. And with the colonoscopy, I can see the polyp, detect the polyp, and remove it at the time of the procedure.
Thank you very much. Why are some people hesitant about getting a colonoscopy? And I think I'm going to know your answer, but let's see.
Yes. So in order to see the colon clearly, it requires what's called a colonoscopy prep. And so when I have patients come into my office to discuss colonoscopy, that is the point in which it becomes clear why people delay colonoscopy. So the prep is not fun. Is probably the more difficult part of the procedure. And what it entails is the day before the procedure, you take a large volume laxative. And so you're going to the bathroom pretty often, and the laxative is not particularly tasty. So people just do not like to do that part of the procedure. And I think that's the main hurdle that patients have with pursuing a colonoscopy. I would say the other hurdle is the fact that it is a procedure that requires anesthesia, and there's reasonable concern about the risk of having anesthesia and going through with a procedure. It's a little bit more invasive than having a radiology study, such as the other screening modalities that we discussed for breast and lung.
Right. Thank you very much. I've heard that too from friends and family that have needed to get a colonoscopy. But I think if you think about the risk that you are taking by not getting a colonoscopy, it outweighs, the prep
Absolutely.
is nothing compared to what you could be going through if you delay your screening. So you always have to think in that mindset, right? Just kind of push through and find ways to get through it. It's for a good reason.
Right.
So can you talk a little bit more about the process you prep for it? What happens kind of after that? And I understand that there are some ways that you can do some of the pre-op or by phone as well. Can you talk about that?
Exactly. Usually, I meet my patients before I do the procedure, and so we will have a consultation in office. But with the pandemic, I think one positive thing that has come about is like the ability to do telehealth. And so I often will see patients initially, especially for colonoscopy screening consults, virtually, which hopefully doesn't disrupt too much of their day. But also provides us ability to get to know each other. I can identify if there's any risk factors that I'm worried about, review the procedure with them to kind of calm some of the fears and make them feel more comfortable with proceeding. And then once we have our initial consultation, the procedure will get scheduled, and the prep or the colonoscopy prep will be sent to a pharmacy. You pick up the prep from the pharmacy when you're directed to do it, and then you'll take the prep the day before. We often recommend what's called a split dose prep, which means you'll take part of the prep on one day, the earlier part of the day before, and then you take the rest of the prep later in the night before your procedure. The day of your procedure, you'll arrive a few hours ahead of time to give us a chance to discuss the risks of the procedure and go over consent forms. You'll need an IV in order to get the anesthesia, and then you'll meet the anesthesiologist as well as myself. And then the procedure itself, it really takes about 30 minutes. It doesn't take that long to complete. And then after the procedure is done, usually wake up within a few minutes, maybe 10 minutes, and I can review the results with you at that time. If there were polyps that were removed, they're sent to a pathology lab, and they can determine the type of polyp that was removed. And this sort of can dictate when I recommend you come back for your next colonoscopy. And then I'll get in touch with you by phone or by letter to discuss the results.
Okay, thank you. Or do you, is it good to have someone with you during this process to drive
Yes,
home, or so you would want
absolutely. Yeah, that's thank you for bringing that up. We do require you to have a driver the day of the procedure because of the anesthesia that you'll have. You're not allowed to drive. We also, depending on the location of the procedure, are doing COVID-19 testing either the day of the procedure, right beforehand, or 5 days prior. And I think this safety mechanism is important, during these times.
Wonderful, thank you. We have a question for you from Betsy. Has a question about IBS. She says, can IBS, she says with C, I'm not sure if that's with.
Probably constipation.
Okay, thank you. We always know our experts can help us understand some of the questions that come in. So she's asking, can IBS with C cause cancer?
No, you're not at high risk of colon cancer with irritable bowel syndrome. And so the disorder that I mentioned earlier is inflammatory bowel disease, which again includes Crohn's disease and ulcerative colitis. But with irritable bowel syndrome, you're not at higher risk.
Thank you very much. One last question for you before we just get our final questions for our experts. Going back to a screening question, is it safe? A colonoscopy, is it safe for you to do?
Yes, colonoscopy is safe. Colonoscopy is considered to be a low risk procedure, which means there are low rates of a serious complication due to the scope injuring or causing any damage to you. So yes, it is a safe procedure.
All right, thank you very much, Dr. Barrow. What I'm going to do, I'm going to just ask a few more questions for our experts. If you have any additional questions, please post them in the comments. Going back to you, Dr. Flaim, are all the cancer screenings that we talked about today, are those covered by insurance? And what if the viewer doesn't have insurance? We did talk about lung cancer, but can we just address all of them in general?
Absolutely. So yes, screening exams are covered by insurance as long as you meet the screening criteria. And each type of screening exam has their own criteria, but as long as you meet those criteria, insurance will cover them. I think MedStar is pretty sensitive to the financial impacts of the pandemic and livelihood impacts that it's had on people. So we do have resources and programs available. If you have access to a computer, medstarcancer.org, I think you can look up that site and see which programs would benefit you for various screening modalities.
Thank you very much. And any final advice or any other messaging that you would like to share with our viewers about the importance of cancer screening?
Sure. I mean, as scientists, we love data, and the National Cancer Institute has released a statement that they are conservatively estimating 10,000 excess deaths over the next 10 years from missed screenings for just breast and colorectal cancer. That doesn't even hit on any of the other, types of cancer that we might see. So I think that's a pretty shocking statistic. If you have any questions or concerns, we're here for you and are happy to answer your questions to make you feel comfortable, to make sure you do come and get your screening exams.
Thank you very much, Dr. Flaim. Clara, what message do you have for our viewers as we wrap up our broadcast?
I would just say, for lung cancer, we're still working really hard to get the word out. And, we do have a method to detect lung cancer early with our low dose CT scans when lung cancer is the most treatable. So we recommend it for patients who are within those guidelines. It's a painless procedure that takes hopefully less than 10 minutes. And if you're a smoker, we definitely want to talk with you. Not only obviously to quit and reduce your risk, but also what risk that may have already posed on your potential health. So.
Thank you very much. And Dr. Barrow, wrapping up with you, what message do you have for our viewers today as we wrap up?
I just want to continue to emphasize the importance of, screening for colorectal cancer. Currently, the guidelines state start your screening at age 50, but guidelines are beginning to change and be revised to start your screening at age 45. So if you're between age 45 and 50, definitely discuss colon cancer screening with your primary care doctor. And also, if you have any hesitance about colonoscopy, there are the stool tests that are available. And so really the best screening test is the one that the patient is going to follow through with.
Wonderful. Great advice. Thank you all very much for joining us today. We appreciate everyone's viewership. We appreciate your questions. If you'd like to schedule a colon cancer, or not just a colon cancer, a cancer screening, please visit medstarhealth.org/screenings. You can also call 443-444-6144. Lots of fours. I will repeat that again, 443-444-6144 to talk to our cancer screening access specialist about your risks, and we'll get you scheduled for a screening. I hope you all have a wonderful day. Stay safe and healthy. And thanks again to our experts for joining us. We appreciate it. Bye, everybody.
Thank you.